So, a very good evening to all of you. A very auspicious day of observation of stroke as a important world part of the world health. In the world health scenario, the position of stroke has been remarkably recognized, and long last, we have reached a stage where stroke is beginning to get an extremely important place in the management of diseases and management of health-related problems. And we in India has actually played an extremely crucial role in this with a lot of neurologists, especially even right from the young career days. Most of us who are right now here had taken up a special interest in stroke much about more than 2 decades back. And that's the scenario with a large number of Indian neurologists as well. And so we have played a very, very important role in propelling stroke to the attention of the World Health Community, the World Health Organization. And I remember, as you all know, in 1900s, this was recognized. The stroke is becoming a serious problem and something has to be done for stroke. NIH started giving grants. The EPA got discovered as an effective modality in 1996. And in 2004, in Vancouver meeting, many other organizations had come up, World Stroke Federation, International Stroke Society, and they were merged together by Professor Hachinsky, etc., together made a single organization called World Stroke Organization. It actually realized as a single organization with a consensus, though only in 2006. And then from that time onwards, there has been a really reckoning of this important, a lot of youngsters taking interest in stroke, and year by year, various, the World's Stroke Day, it was on the October 29th declaration of the World Stroke Day was in Vancouver in 2004. But subsequently, every World Stroke Day, there was very important themes. And this particular year, the theme, as you all know, is Together We Are Greater Than Stroke. What does that mean? If we join together, we can certainly prevent strokes, we can take care of acute stroke patients, and we can also take care of the stroke patients after they have had a stroke. So it's very, very apt that on this particular day, this time, the Neuro Rehabilitation subsection of the Indian Academy of Neurology and the Indian Federation of Neuro Rehabilitation has come together to have a very special session. And here, as I told, together we are greater than stroke means we can certainly control strokes, and we can certainly prevent stroke. And prevention, there are 3 prevention: primary prevention, secondary prevention, and tertiary prevention. And when it comes to the tertiary prevention, that is again extremely important, because we cannot prevent all the strokes. We cannot even prevent somebody from getting a stroke after they have had many a time. But once they have had, somebody has had a stroke, it's extremely important to look into what we can do to improve the quality of their life, to improve the, to bring them back to the norm stream, to bring them continue to enjoy the life. And this is tertiary prevention. And this is a very important way of showing that together we are greater than stroke. And on this note, I would now request we have 3 very, very important talks today, what we can do to prevent the complications and the recovery of the stroke immediately after the stroke, then in the intermediate period, and also on a long-term basis. We have 3 very eminent speakers who have all been actually working in this field with a lot of passion. So what we are going to hear today is from the horse's mouth, those who have been really active in the fields, who have a lot of passion about it, and who are continuing to do quite a lot in this field. It's a very unique opportunity to have these three stalwarts, Professor Dr. Nirmal Surya to begin with in the acute rehab, and then Dr. Abhishek talking to us about the continuation of the rehabilitation, and then Dr. Pandian, Jairaj Pandian, who is also the president-elect of the World Stroke Organization, going to talk to us, and Dr. Nirmal Surya, the president-elect of Indian Stroke Association. So all of them are going to speak to us on the various aspects of the stroke rehabilitation. We will begin with...
Thank you very much, sir. With the permission of the chair, because I would also like to introduce, sir, the chair as well. So first of all, on behalf of the Neuro Rehab subsection of the Indian Academy of Neurology and the Indian Federation of Neuro Rehabilitation, we welcome everyone to this symposium on stroke rehab on World Stroke Day 2023. As much as there has been advances in recanalization measures, so has been the scenario in rehab realm. More so, the rehab modalities and the technological advancements have taken a leap in the recent decade with different effectiveness when applied during the different stages of stroke, that is acute, subacute, and chronic. And hence, to discuss on the topic, we have experts from across the nation with the highest caliber, chairing the sessions and speaking on the topic. It is a very joyous moment for me to introduce the experts whom I have idolized as I grew. So can I please have the slides, ma'am? So first, to introduce our chair, Dr. Sunil Narayan, sir. He is the head of the Department of Neurology in JIPMER, Pondicherry. He is the chairman of stroke subsection of the Indian Academy of Neurology, and it is a pleasure that we have the chair of the stroke subsection, the chair of the neuro rehab subsection, the president of the Indian Federation of Neuro Rehab, Dr. Nirmal Surya, sir, and the president-elect of the World Stroke Organization, all in one platform to discuss how to take forward the rehabilitation of these patients. Can I please have the slide, ma'am? So he has over 101 PubMed indexed publications. He is organizing chair of various conferences, including Tropicon 10, and he is also expert member in DCGI, DST, ICMR. He has fellowships in various professional bodies such as the American Academy of Neurology and European Academy of Neurology, Royal College of Physicians, Indian Academy of Neurology, NSI. He is TAN President, JSS President, and IA and Stroke Subsection Chairman. We welcome you, sir, to chair our session. Dr. Arvind Sharma, sir, who is head of the Department of Neurology and Stroke Specialist in Zydus Hospital, Ahmedabad, and he is the secretary of the Indian Stroke Association. He is assistant professor of neurology in NHL Medical College and SVP Hospital, Ahmedabad. He is board of director of World Stroke Organization. He is executive member of the Indian Academy of Neurology. He is vice president of the Society of Neurosonology. He is the director of Brain Heart Foundation. He has fellowships in stroke neurosonology from University of Alberta, Canada, and he is also trained in cerebrovascular ultrasonography as the National University Hospital, Singapore. He has McKinney Award to his name, and he is a member of various organizations which are esteemed and prestigious across the globe, and he has several publications in international and national journals. We welcome you, sir, to chair the session.
Thank you.
Can I have the slides of the speakers? Next, ma'am. Next, ma'am.
So, Gohan, can I introduce you? Means you're yeah, it doesn't look good, right? Gohan, can you go back, please?
Yes.
Gohan. Yeah. So, it will be my pleasure to introduce the moderator, Dr. Gohan, who is MD-DM Neurology, and he has an affiliation as a clinical fellow for Division of Rehabilitation Medicine at National University Hospital, Singapore. At present, he is pursuing it, and consultant neurologist at BJ Institute of Neuroscience and Neuro Rehab, Trichandur, a convener of the Neuro Rehab subsection of Indian Academy of Neurology. He has 40 publications, and area of interest we know as he's convener of this neuro rehab. He's interested in neuromodulation, botulinum toxin, pain management. And he's a President Gold Medal for DNB Neurology. And he has received University Gold Medal also. He has received many gold medals, I can see. And he was a COVID warrior that was a very difficult phase during its tenure at Madras Medical College, and contributing author for the South Asian edition of Dijon, the neurological examination. We welcome Dr. Guhan as a moderator.
Thank you very much, sir. Next slide, ma'am. So we have an esteemed speaker panel today. To start with, my mentor, Dr. Nirmal Surya sir in WFNR mentorship program, and he is chairman of the Surya Neuro Center, Mumbai, and associate professor of Bombay Hospital Institute of Medical Sciences, Mumbai. And his area of interest is epilepsy, stroke, and neuro rehabilitation. He is the president of Indian Academy of Neurology, founder president of IFNR, president-elect of AOCNR, AOSNR, founder, trustee, and chairman of Epilepsy Foundation India, treasurer of NATAI, member at large of WFNR, CEO of ICHA, past presidents of Maharashtra Association of Neuro Rehabilitation, and he has the prestigious Kenneth M. Wisted Jr. Award awarded to him by the American Academy of Neurology. And his CV runs for another pages in PowerPoints, and it was very hard for us to limit it to one slide. We welcome you, sir. Thank you very much for your time, sir. We have the chair of the Neuro Rehab subsection of the Indian Academy of Neurology, Dr. Abhishek Srivastava, sir. He is a neuro rehab specialist and director at the Center of Rehabilitation, Kokilaben Dhirubhai Ambani Hospital, Mumbai. He is secretary of IFNR, botulinum toxin. His areas of interest include botulinum toxin for spasticity, rehab robotics, and hyperbaric oxygen therapy for disorders of consciousness. He is WHO fellow for TBI rehab guidelines, chair SIG multiple sclerosis WFNR, secretary IFNR, convener of neuro rehab, the chair of neuro rehab subsection of IAN, the organizing secretary of WCNR 2018, and he is also an IAPMR gold medalist. He just wheels his injections for Botox, and that's a beauty to watch. And we have seen him in various workshops during our residency period. We welcome you, sir. And finally, to our elite speech panelist, Dr. Jairaj Pandian, sir. He's professor of neurology and principal, Christian Medical College, Ludhiana, president-elect of the World Stroke Organization, past president of Indian Stroke Association, and his areas of interest include stroke, autonomic disorders, and clinical trials. He has Global Stroke Services Award by the World Stroke Organization, SKOCH National Award for Top 25 Innovative Models in Community Care. And the last line is whooping 230 peer-reviewed publications with a citation of about 170,761 with a H index of 68 and an I-10 index of 146. He is inspiration for many academicians to have a high publication rating. We welcome you, sir. Thank you so much for your time, sir. Over to the chair, Dr. Sunil, sir, and Dr. Arvind, sir.
Yeah, Arvind.
Yeah. So now we request the first speaker, who is the president of Indian Federation of Neuro Rehab, to deliver his first talk. We welcome Dr. Nirmal Surya to deliver his talk.
Thank you very much, Arvind, and convener and chairperson Sunil. I am going to talk a little bit different today about the early rehabilitation after the stroke. And can I have the second slide? So you can continue this. As you all are aware that 10% of stroke survivors recover almost completely. 25% recover with minimal impairment. 40% experience moderate to severe impairment that require the special care. 10% require care in a nursing home or other long-term facility. And 15% die shortly after the stroke. And approximately 14% of stroke survivors experience a second stroke in the first year following a stroke. So these are the data which tells us today that how difficult it is and why it is important that on the day of World Stroke Day, we should create an awareness among the people. If you look at the stroke pathway, the primary prevention is something which needs to be done. Then if you look at acute acute phase, then there's a learning to live with a disability, and finally living with the disability. You have rapid detection, thrombolysis, that in the early part, then you stroke unit care, tailored community care, self-care, and finally access to the leisure employment and other opportunity. And this follows about the quality information for users and career in professionals, a workforce skills, and preventing a further stroke or TIA. Next, please. So why early rehabilitation? So there are evidence from clinical trials support the premise that early initiation of rehabilitation favorably influences recovery from the stroke. And when the initiation of therapy is delayed, patient may in the interim develop avoidable secondary complication. Studies also show that stroke rehabilitation can improve functional ability even in patients who are elderly or medically ill. Next, please. So that's the reason early rehabilitation is important. Next slide. So how early is early? If you look at all the data, the predominant thing comes is within 24 to 48 hours of admission. And programs should be planned with a clear timeline, target, and objective. So early rehabilitation in literature is suggested that rehabilitation treatment that is commented within 1 month. But is this the right approach? Next, please. If you look at this, what happens when a patient is confined to the bed? So you can have various problems due to the misuse, disuse, loss of muscle strength, which, muscle lead to atrophy and a loss of muscle strength, around 12% per week. There may be bone loss, both cortical and trabecular bones are lost. 1% per week of bed rest, nearly 50 times that of normal age-related bone loss. So you can see that there is a loss of strength and endurance and the bone loss. Next, please. Similarly, there can be changes in the gastrointestinal slowdown, which may be reduce the sense of taste, smell, loss of appetite, or there can be increased transit time, constipation, or respiratory insufficiency or inefficiency. And it is possible that there may be a reducing tidal volume by as much as 78% to around 32%. And therefore, it is important that early rehabilitation must be started. Next. Changes due to the disuse in the cardiovascular insufficiency. You can have myocardial thinning, particularly in the ventricular region, common in both male and female bedridden patient. Urological problem due to the detrusor muscle weakness, and then cognitive slowdown like orientation deficit, unreality of memory, declining decision capacity, intellectual disengagement. Next. There can still be dysregulatory changes like hematological, which can be reduction in blood volume, or the release of atrial natriuretic peptide that initiate diuresis, leading to significant water loss. There may be shift of blood stretches. There can be effect on ADH release from pituitary. And then there can be increased viscosity and coagulability. And there can be a total hemoglobin level which is reducing and drop. So these are some of the hematological things which can happen. Next. And then dysregulation also causing to the vascular, and we all know that postural hypotension is a serious problem, particularly in elderly people. And it is one of the first problems to be seen in bedridden patient and has been noted after as little as 20 hours of bed rest. Next, please. Then there can be changes due to the dysregulation in gastrointestinal system, like increased acidity, reflux and gastric inflammation. There may be airway obstruction, increased resistance in the airway, and loss of elastic recoil. Next. And there can be posture or positional imposed soft tissue stress loss or tissue breakdown. An experiment has shown that ligament stiffness and load-bearing ability drop to 69% and 61% below normal if patient has not been mobilized. And within 2 to 3 weeks of immobilization produces a much firmer contracture, and this is a frequent complication of bed rest. Next, please. There can be a posture, prolonged pressure that is greater than capacity pressure of 32, resulting in ischemia and necrosis of underlying tissue. There may be areas of skin which are stressed, and there can be compression between the bone and hard surface, such as bed or the chair and bed source. Next, please. So what happens when patient confined to bed in emotional or psychological despair? Persistent stress, persistent anxiety, fear, no regroup time, add-on and cumulative emotional and psychological injury, and no repair retreat. Next. So post-stroke rehabilitation, what are the current trends? Rehabilitation therapy begins in the acute care hospital after the person's overall condition has been stabilized, say within 24 to 48 hours after the stroke. And the first step is promoting independent movement because many individuals are paralyzed or seriously weakened. They are prompted to change the position frequently while in the bed, engage in passive or active range of motion exercises to strengthen their stroke impaired limb. Patient may progress from sitting up and being moved between the bed and a chair to standing, bearing their own weight, and walking with or without assistance. So these are from the National Institute of Neurological Disorder and Stroke. Next, please. Now, stroke unit care is where the rehabilitation should begin. Patient admitted to hospital because of an acute stroke or TIA should be treated in an interdisciplinary stroke unit. And interdisciplinary teams should access patient within 24 to 48 hours of admission and formulate a management plan. And clinicians should use standardized, valid assessment tool to evaluate the patient's stroke-related impairment and functional status. Next, please. So what are the evidence for early rehabilitation? The impact of very early mobilization on recovery after stroke is not clear, and we will come to the trial. Care in stroke unit is recommended. Very early mobilization, helping patient to get up out of bed very early and often after the stroke symptom onset, is performed in some stroke unit and is recommended in many acute stroke clinical guidelines. There are one small trial which found no difference in death and dependency at 3 months between those who undertook an early intensive mobilization protocol and those who did not. So no significant harm were identified, and but at present there is insufficient evidence to support or refute the effect of routine very early mobilization after stroke, and several trials are currently ongoing. Next, please. Benefit for early rehabilitation animal model has been there. There are numerous studies, and this is one of the paper from China, which shown that animal exposed to the locomotor exercises beginning 24 hours to 48 hours post-stroke have better behavioral outcome, smaller ischemic volume than control animal who received delayed or no exercise training. Next. Evidence for harm of early rehabilitation in animal has also been noted by Lee et al. That exercise beginning 6 to 24 hours post-stroke led to an increase in inflammatory cytokinins, whereas the same exercise commencing 3 days post-stroke decreased those cytokinins. Next, please. Benefit of early rehabilitation in human trials is a EVER trial, which is a phase 3 multicentric randomized trial. And in the past 5 years, 4 trials has sought to test this hypothesis, and one of them, robust, is EVER. Next. And what is EVER trial? Dr. Jairaj Pandian is here. He is the one who was part of it. Next, please, with Julie Bernard, one of my colleagues at WFNR. Initiation within 24 hours of stroke onset, focus on out-of-bed activities, sitting, standing, and walking, addition of at least 3 out-of-bed session to standard care, and researchers were surprised when Abbott found a small but significant reduction in odd of a favorable outcome that is modifying MRS 0 to 2 at 3 months after stroke in VM group. Next, please. One notable limitation of this trial is shift in practice to early onset of therapy within SC group. And statistically significant was small because mean 18.5 versus 22.4 hours. So that was intervention and control group. The difference in intensity, however, was large. The intervention group spending almost 3 times longer out of bed than control. That is 201.5 versus 70 minutes. And this probably had a greater impact on the outcome than the difference in time to first mobilization. Though not statistically significant, the complication with the largest between group difference was stroke progression. Thus, the EVER trial may provide preliminary evidence for a relationship in human between intensive, very early activity and infarct expansion. So that's something which has come out. Next, please. If further the practice clinical guidance with respect to optimum timing, frequency, and quantity of out-of-bed activity, the AVOT group completed a pre-specified dose response analysis of all the trial participation. And this says that time from stroke onset to first mobilization, mean number of out-of-bed sessions per day, and the median minutes of out-of-bed activity per day are critical. Next, please. So this analysis suggests that shorter and more frequent early mobilization, not exceeding 10 minutes per session, in at least 2 and as many as more than 10 sessions per day as tolerated, with low upper limit on the number of sessions, can improve the chances of regaining independence after the stroke, controlling for age and severity. Significantly, it shows 13% increase odd of a favorable outcome with each additional out-of-bed session per day, keeping the time to first mobilization and daily amount constant. So time spent in out-of-bed activity while keeping the frequency and time to first mobilization constant reduces the odd of a favorable outcome. Next, please. So again, the single-blinded, the very early mobilization on functional status in patient with acute stroke, it was a single-blinded randomized control trial from Chipala and Sharma. And they have done is 5 to 30 minute session of out-of-bed activity at least twice a day for 7 days, beginning within 24 hours of stroke. And their primary outcome was change in functional status, that is BI, from baseline to hospital. And the interval group was mobilized an average 12 hours earlier. Significant greater improvement in BI than control. That was median was 1335 versus 70.5. So difference was partially sustained at 3 months. So that's something which was very interesting. Next, please. Next slide. So on recent observation study is worthy of mention. These are some of the studies, the association between early rehab as a physical or OT delivered within 72 hours stroke and outcome in acute ischemic stroke patient who received TPA. And primary outcome was functional independence, that's MRS 0 to 2 at discharge. Early rehabilitation was significantly associated with functional independence. It provides reassurance on the safety of mobilizing a stroke patient early after TPA and suggests that doing so may be benefited. And it should be noted that 72-hour time frame differ from AVOT and the other early recovery trial. So even thrombolysis patient can be mobilized early. Next, please. Another multi-center study which examined the role of timing for 2 different commonly used physical therapy program, that is PNF and CT. And at 12 months, there was a difference favoring the early group in BI with no difference in between the 2 groups. And study also showed benefit of early over later initiation of therapy, but not a robust one, as benefit was seen on only one of the 2 outcomes. But most subjects in this study began therapy about 24 hours, but less than 48 hours from the stroke onset. So trend is to start early therapy. Now, there are non-invasive brain stimulation in motor rehabilitation, and NIBS in early stroke motor rehabilitation is being published in past 5 years. And most of these NIBS studies are single-centered without adequate sample size. Therefore, results are mixed and inconsistent. TDCS, a recent study suggests that doses presently used are far below its safety threshold in animal model, and underdosing could be a major barrier to success in an IBS stroke unit. We need to do our Indian study and bring the protocol. Next, please. Robotic, there are 3 studies of robotic intervention in early stroke rehab. Robotic tilt tables, stepper training beginning within 5 days of ischemic stroke or with or without FES against SC, or leg strength increased significantly in both experimental group compared to the control group. And another study of 34 ischemic or hemorrhagic patients with 2 weeks of onset compared performance-based ankle board training of dorsiflexion and plantar flexion via video game against passive manual exercises. And ankle board group had a greater measure of symmetry and longer non-paretic step line. So these 3 small trials shows promises in the use of robot in early stroke rehabilitation. Abhishek will tell us more about this detail. Next, please. Aphasia, there are early aphasia therapy studied in 5 recent RCTs. Most robust of this is rotundum aphasia therapy study. And There are the average 24.5 hours of therapy during the treatment period, a dose considerably higher than typical standard care. Only 29% reach pre-specified minimum threshold of 28 hours. Intensity may be the key to success in early aphasia rehabilitation. And there is another Australian study which had a higher percentage of patients with severe aphasia than RATS commenced therapy about 5 days sooner. And this VERSE trial should also help to clarify whether very intense therapy does provide benefit as suggested by RAT3 post-hoc analysis, specifically in most severe aphasic patients. Next, please. Neglect. There is current evidence does not support the use of hemifield patching in the acute phase of stroke, but mirror therapy may be a promising treatment. HAP trials highlight the need for biomarker to better predict the course of neglect in an individual patient. And given the spontaneous resolution of neglect, in order to prove the benefit of early intervention, we need methods to predict who is likely to recover spontaneously and who is not. Next, please. So to summarize, according to review established in stroke, stroke rehabilitation should be initiated immediately after the onset to achieve the optimum result. Previous meta-analysis had demonstrated a positive correlation between early rehab and improves outcome. The optimum time to begin rehabilitation after a stroke remains unsettled. Literature review has shown inconsistent result for effect of early rehab versus delayed rehabilitation. Recent trials of early mobilization, aphasia, dysphagia, and upper limb retreatment have demonstrated that intervention commences within 7 days of stroke can aid the recovery. Intensive therapy in first 24 hours may be harmful, and early intervention was associated with a 5 times greater risk of dropout than that of a patient with delayed start of the treatment. Therefore, while there is some inconsistency in the literature, it appears that initiating rehabilitation as early as possible after the stroke onset can lead to the improved outcome, though the intensity and timing of intervention should be carefully considered on a case-by-case basis. Next. So thank you very much. Next slide. 31st October is the last slide, please. The 31st October is the last day to send the abstract for the World Congress in Neuro Rehab. And I request all of you who are here interested in the rehabilitation should come to the Vancouver, which is from 22nd to 25th May in Canada. Thank you.
I think we will have the discussions after all the 3 talks are completed.
Okay.
Right. Okay. So shall we go on to the next talk? That's by Dr. Abhishek.
Is it visible, sir?
Yes. Yeah.
Wonderful talk, Dr.
Thank you, sir. After presentation by Dr. Surya, let's talk how can we take rehab forward in the subacute stage. As we have seen, stroke can cause multiple impairments, which mean difficulties in language, speech, cognition, behavior, swallowing, vision, sensations, motor loss, and better bowel deficits. So our job in rehab is to identify all these deficits and train these patients to prevent disability to happen. Otherwise, again, a lot of dependency in the long term. So if you ask people about stroke rehab, what first will come? Therapy. Now it's therapy, therapy, and therapy. Beyond therapy, many things have changed in the last 15 years. We'll see one by one in short how things have changed for post-stroke rehab care. So how does neurological recovery happen after stroke? There are some facts. First is spontaneous recovery, happens first 3 to 6 months. Second is functional recovery, which is unlimited. Primary plasticity and role of rehab. Same with neurological rehab, we have 2 types. A compensatory approach. If you can't walk, give a stick, train to walk, very well recognized. Second is remediational rehab. Can we restore function by reducing the impairment? Can we make language better? Can we make speech better? Can we make movement better? This was the current talk. We all know we can repurpose the brain in first few hours, very well known, but we can start some drugs now very, very early, which can have better language outcome in long term. It's possible now. And what happens in the first few months is the most important thing after stroke. Brain recruit additional areas to perform new function, or other parts of brain take over function. This ability of brain to change in response to a stimulus is called neuroplasticity. What we are doing in rehab primarily is to somehow harness or trigger that plasticity. Do it by two ways. First is intensive training, called as experience-dependent plasticity, and third, by biological treatments like medications, drugs, HBOT, stimulation, and so on. Same way, we have a continuum of care for stroke, we have intensive care units, we have stroke units. What we need now is to have acute inpatient rehab units. Patients who are medically stable, neurologically stable, but require medical monitoring, as well as disability in 2/6 of mobility, self-care, communication, swallowing, bladder, bowel, achievable goals, have to be treated in acute inpatient rehab unit. And those patients who are stable medically, can manage 3 hours therapy a day, can go to a daycare unit, not to stay in the hospital. And those who need minimum care can go for outpatient or a community rehab program. So we have stroke units now. Most of the hospital should open acute inpatient rehab units in hospitals now to provide continuity of care for these stroke patients. These are AHA, ASA, APMR, IFNR guidelines. It says that every stroke patient who is a candidate for post-acute rehab should receive organized rehab care, level class A, evidence A. Also, those patients who require inpatient rehab care should be managed in an inpatient rehabilitation facility, IRF, not in a nursing home facility or at home. And last very important point, early supported discharge services is only reasonable for mild to moderate strokes. It's a Western model of care, but in India, patients who have, even abroad now, patients who have significant strokes or severe strokes have to be managed in an inpatient rehab facility to maximize the output in next few months. A team is required. Team members are very, very important role to play. You need a neurologist, neurosurgeon, a rehab physician, nurses, physical therapists, occupational therapists, speech pathologists, psychologists, social workers, orthopedic nutritionists, all are required. And they should work in a interdisciplinary multi-phase model of care, not medical model of care. What are the interventions we do in this stroke rehab? There are 5 basic concepts. First is the continuation of medical function. These patients still have tubes, they have diabetes, they have hypertension, they have medical problems. You treat them. Second, prevent and treat secondary complications. Aspiration, DVT, pneumonia, UTIs, spasticity, contracture, pressure ulcers. Third, provide them training for sensory motor function. Provide them training for cognitive, communicative, and solve problems. And fifth, treat psychological and social issues. That for the prescription is quite long, which includes all these things to happen together to consider goal-directed management to help these patients. Then short one by one, medical function, some important points. When you see the first concept is ICU, when to start some medication. Always remember, some medications are not good for stroke recovery, which are commonly seen in the ICU. Please talk to intensivist and treat these medications if you can. They harm stroke recovery. They call us detrimental drug by Goldstein, very old concept. Then people who have massive strokes require decompression surgeries. If you give them HBOT in the initial phase, one of our studies have shown that people can do better. Oxygen therapy can help to reduce brain edema in such patients. Now, medical complications and medical emergencies are happening in these patients. Why? We have more older people, more sicker people undergoing stroke rehab. And these medical emergencies and complications impact the rehab interventions, delay functional progress, to the length of stay. There are many, many things which can happen in these patients. A big list is there. Primary neurological, cardiopulmonary, endocrine, MSK, skin, bladder, bowel. I'll mention 3 or 4 of them which are commonly seen. Aspiration pneumonia is the most important factor which can delay rehab and can cause mortality in stroke patients. Please follow aspiration precautions. Do follow evaluations for all these patients starting any oral feeding. Shoulder pain, very commonly seen in all stroke patients. The 5 basic reasons: subluxation, spasticity, cuff problems, capsulitis, or CRPS. Remember, treatment different for all of them. Subluxation requires support. Spasticity requires medication with botulinum toxin. Rotator cuff problems will require a supraspinatus nerve block. CRPS will require cerebral ganglion block. So identify the cause for shoulder pain, and treat it accordingly. Other patient can't do rehab. Spasticity will happen. All these patients and they recover. If it is generalized, they need the oral medication. If it's focal, multifocal, they need botulinum toxin or phenol along with medications. Now, always remember, before giving botulinum toxin, identify proper goal setting, identify proper muscle selection, then only inject. And if you inject it wisely, you can see people can walk without sticks because of better spasticity management. Always, our guidelines say that some type of estimated guidance with botulinum toxin injections. The ultrasound, the stem, pre-EMG. You can do whatever you are trained for USG, do USG, you will do E-stem stimulation. Also, if you give a guidance, you give lesser dose. Actually, it's more confident for the patient. Give guidance for what to talk with their patients. Also, we miss the bladder. One of our studies is published long back. It did UDS at 28 days after stroke. 94% of patients had pneumogenic bladder. At least do a basic PVR and a uroflowmetry before after removing catheter to all these stroke patients. If it is above the ponds, it's a overactivity below the ponds in the brainstem can be dyssynergy also, which will require proper medical management for these patients. From cognition and behavior, we have seen patients who say, I have 7 limbs going out of body after a stroke. This is called a supernumerary phantom limb. People have depression post-stroke. So we have to both identify cognitive as well as behavioral problems in these patients. New tests are available. MOCA is available in the Indian population. We also have now computer-based assessment called as Cognistat. It assesses all functions in detail. And cognitive rehab is to identify the missing link and then either do remediation or compensation. Medications like cognitive enhancers like donepezil, rivastigmine, Mementine have some role to play if it is combined with cognitive rehab. Also, there's some guidance for post-stroke depression. Now, meta-analysis says that paroxetine has the fastest and most safer action in reducing post-stroke depression, and duloxetine is the fastest to act. Either give paroxetine or duloxetine, not the older drugs which used to give early to depression of stroke patients. Aphasia, remember we have web test, which is now available in Indian languages also. First, classify what type of aphasia a person is having from anomic to Wernicke of global aphasia. Next step, start therapy. There's a fixed cartoon how to start therapy for people with post-load aphasia. You can do speech language therapy, you can do music therapy, you have behavioral approaches, we have medications, now brain stimulation also coming in. Scott review says that if you do speech language therapy by a trained caregiver over a period of 1 year, outcome is same. So every patient does not need to be in the hospital for speech language therapy. You train the caregivers and then meet them once in a month, give them next type of level of activity. It works equally well in long term. Music therapy is very important role to play. People who have massive global aphasias, they have agitation because of stroke, and music therapy can help these patients, both for improving their verbal output, take to the acute stage. Role of pharmacotherapy, yes, Mementine is being used in motor aphasia, and donepezil is being used in Wernicke's aphasia, and it's shown good results using it for the last 15 years. Most of our patients, it is being combined with speech language therapy to better outcome. Dysphagia, the most related complication of the stroke. Each center has its own way to assess dysphagia. This is our hospital protocol. We assess the cognitive status of the patient, assess behavioral status, check all the cranial nerves, 7th, 9th, 10th. Then do observation of oral trials, watch for oral mechanism, pharyngeal mechanism, then decide what to do. For a simple protocol, you can never miss, especially in these patients. And we have got cartoon for solo therapy, start the compensatory approaches of posture, head tilt, consistency, change the bolus posture, start solo maneuvers, or combine both of them, and then treat in a specific way. If people have tracheostomy, don't get frightened. Do simple test called as modified Ivan test. Give some colored liquid, green color in the mouth, deflate the cuff where it's going. If it's coming in the tracheostomy, the person leaking. If not, it will follow the basic saliva. Then you can put a valve called a passive speaking valve. The person can speak it, and then do something called as fluoroscopic follow study. All the hospitals have fluoroscopy in the X-ray units. Get them solid, let them solid food, and see where the food is going. Go straight, it comes in front, it's penetration. For example, protocol can decannulate most of the patients very safely, stroke patients. And then technology is coming in, it's vital stem. It's an FDA-approved device with the strength of follow muscles, relatively while doing therapy. Even start this in people who have tracheostomy. Help both for aphasia as well as both for dysarthria as well as aphasia. And the motor problems, which is the most common seen after stroke. When to mobilize stroke patients, a lot of discussion about simple, nice guidelines. When not to mobilize, when to out only, when to make them stand. Basically available. Tilt table is used in the beginning to make them stand. Now we have tilt with the FES to make them stand even better in the ICU, very, very early. Now, therapy has multiple approaches. Copath, PNF, Brainstorm, or approaches are there, which is the main cornerstone of recovery in these patients. What we can do beyond these therapy approaches, we'll see. Can use some pharmacotherapy for motor recovery. There are 4 basic trials. First was the FLAME trial for fluoxetine in France, shown good result, but meta-analysis has failed. Dopamine in chronic stroke patients to improve motor outcome, DAS trial, not helped much. The TELOS trial, where they give citalopram in Europe, it is now being approved in the European stroke guidelines to improve motor recovery. You have to 20 mg HS for in people with moderate to severe strokes. Cyberlysin CAST trial has shown some advantage for hand function. Again, it's part of the European guidelines now. But TELOS trial being taken as a benchmark for the European Academy of Rehab, and they were approved use of escitalopram for improving motor recovery in moderate to severe stroke patients. We can make a person stand, how to make them walk, how to improve their motor power. A lot of things have come in last 20 years. We'll see one by one. First are lower limb robotics. There are 5 types of robotic systems: the ankle-based, ankle-bot systems, the stationary robot systems, overground gait trainers, foot plate-based gait trainers, or exoskeleton-based gait trainers. This is the most commonly used device called as Locomat. It's a body weight support harness. This robot makes the person walk. You offer the patient body weight on a treadmill with an augmented feedback of your avatar screen in front of you. So it is not passive walking, it is active assisted walking. First, to make a person walk on the chair, it's called a walk on the treadmill, called as nice. And when they are doing it, they feel the feedback mode, much power generating in the hip and knee, or augmented feedback mode playing game. And the concept is to start with full body weight support, very low speed, full robotic assistance. You reduce the robotic assistance, reduce the body weight support, increase the speed, and the people walk in the community, independent walking. What does the Cochrane review says? It says that every 5th person of stroke who cannot be walked by any other means can be made to walk with the devices. So robotics for lower limb is primarily for non-ambulatory patients. It is not for ambulatory patients. Those who cannot walk will benefit the robotic system versus those who are able to walk themselves. Then upper robotic systems, multiple types are available now. Exoskeleton type, end-effector types, only for wrist and hand, sensor-based, only for shoulder. We follow what is hand studio concept. We use 3 systems, one for the shoulder called as Army of Power. Day 7 post-stroke with more motor recovery, but can sit on the chair, put it playing game on the computer, then robotic assistant. Again, it is active assistive training. Robot will sense what you cannot do and help you do this function. You get some power in the shoulder, focus on the arm, what is Army of Spring, concept remains same. God has made not to accept to do a functional task. What you're doing is you're cutting an apple, you're playing games, which is an everyday task, help of robotic assistance. Only hand is involved, it's called as an army, it's called as an army concept of immediate. This works only for the hand. Now, what the Cochrane review says that people who use robotic system training around conventional therapy, a better arm function, better arm muscle strength, better idle activities, very rare adverse effects. Good thing to add to conventional rehab. Always remember, all these technology are add-on. If you can provide basic therapy, robotics will help beyond that. Those able to walk want to walk better. If balance is involved, it's called as dynamic posture training. We published many years back in chronic stroke patients. They're able to walk better with about training. FES can help people who have ankle weakness. EMG biofeedback can also help people who have distal motor weakness. AFO, now we have carbon AFO for these patients. Improve better walking ability, better balance, better impairment. Virtual reality is coming a big way in subacute or chronic stage now. Very good for arm function, not good for gait, speed, or hand, but it's mainly used for better arm function in recovering stroke patients. Circuit training, if you are admitted for stroke rehab, or those who are in community for long-term care, if you do training the endurance concept, they have better outcome, less of stay can be reduced. They will train in the inpatient rehab. CIMT for hand function is the most researched therapy. Most papers available on CIMT, effective training. Difficult to do. You have to use the affected arm 3 hours per day minimum in 1-to-1. If you can do that, it leads to better outcome in hand function. Mental practice, yes, here's the what way to do function, help for upper limb motor recovery. It's evidence-based now in Cochrane review. Mirror therapy, very low-cost system, better for motor function, better for ADL activities, good for neglect, good adjunct to motor rehab, especially people with neglect and hand function problems. So if you summarize, physician-supervised, organized post-acute care, multidisciplinary team whose work was coordinated through regular meetings and dedicated to rehab, a better function. It's been proven 20 years back. And it's my favorite slide to understand the whole concept. You know, we can repurpose the brain in first few hours. We also know swelling will come down in first few weeks. And with that change itself, in first few weeks, deaths die down by about 3 months. So we say more recovery of 3 months, but it is wrong actually. If you start anticipating in the first few weeks, you get something new, called as training into the organization. That will not die down very, very early. Just one case example, young boy, 20 years, massive ICS stenosis, ACMC global infarct. This is about 9 years back. And when taken with the creatinine, transferred to further rehab at about 4 weeks. To do it, rehab all these things together. Awake, alert, possibility, and aphasia, dyslithia, hemiplegia. What you do, mechanism of stroke paralysis, antispastic medication required, pharmacotherapy for cognitive function, fluoroscopy for swallowing, decannulation, USG PVR, give splints, physical therapy, occupational therapy, speech, all have done together simultaneously. We call it a 6-6-6 concept. These patients get therapy 6 hours per day for 6 weeks minimum to bombard the brain to like, 6 months. He joined this college here. Another lady with ischemic cardiomyopathy, very bad EA 15%. Functional MRI, we showed that the supplementary motor areas have taken off function. At discharge at 3 months, she was like this. Another boy with Apla syndrome, very bad, massive ICH. How he was. He now works in architecture. Another guy running marathon had a massive stroke, and now he's independent doing his work. The whole concept is stroke rehab was taken primarily as a compensatory strategy. If you can't walk, give stick, can't talk in sign language, can't eat, put tube. No. That led to further learn non-use. So current focus on rehab is to identify and treat the impairment. Treat cognition, behavior, speech, language, swallow, motor, bladder power, all together simultaneously in the first few months to give them the best chance to recover long term. Thank you very much.
Thank you, Abhishek, for that beautiful illustrations. As we decided, we will take up the discussion at the end of the next talk. And I invite Dr. Jairaj Pandit, who already introduced, to talk about the chronic phase post-stroke rehabilitation. We already heard about the immediate and the post acute phase rehabilitation, and on the chronic phase rehabilitation.
Yeah, thank you, Dr. Sunil Narayan, and Dr. Abhishek has made my life simpler now, and there's some overlap, I would say, between subacute and chronic, but I'll just stress upon what he has not mentioned in his talk, but there will be some overlap. So recently, in the World Stroke Congress in October, there was a major document that was released, WHO Lancet Neurology Commission, and where we came up with about 12 pragmatic recommendations overall, and for each category, acute pillar, rehabilitation, prevention. So we had separate recommendations. So for rehabilitation, I want to emphasize here that globally we need to promote multidisciplinary rehabilitation services. Training and capacity building is needed because there is a huge gap in terms of availability of human resources in the area of rehabilitation, funding from the government for insurance coverage and reimbursement, and implementing evidence-based guidelines. And that is where Dr. Abhishek had mentioned, what are the interventions, and then how it has to be incorporated in the guidelines so that it is uniformly followed. Task shifting is important, particularly in low resource settings, telestroke rehab, and repository for best practice protocols. So these are the pragmatic recommendations from WHO and Lancet Neurology Commission. And I will just quickly go through this slide, at which Dr. Abhishek also showed in a different format. In the hyperacute phase, we had the cell death and hematoma expansion if it is ICH, and there is inflammation within the first 7 days. Then you have the spontaneous recovery, endogenous plasticity, but as he mentioned in the few slides, that the rehab, how it can reorganize the nerves, the neurons, and so this is a summary. And in the chronic phase, people may say, first 3-6 months, you'll have maximum recovery, but after that it may stop. But it is not that. That's not the case. As long as you continue, you use multiple strategies, interventions, still we'll be able to gain functions. So evidence-based approaches, a lot of things have been covered. I'll just quickly go through. This is, this is a mirror therapy, and there is class 1 evidence for ME neglect in thalamic and parietal lobe strokes, and also in motor recovery. Even if you don't have fancy stuff with you, you can have a low-cost version of this mirror box, which can be made within the hospital. So what happens, we know that there's a human mirror neuron system. There are 3 areas of the brain which are primarily involved: the posterior superior temporal gyrus and inferior parietal lobule, inferior frontal gyrus. And so the mechanisms, I'm not going into the depth of it, but these are the areas that are involved, and it recruits more for fibers and basically stimulating the mirror neuron system. How frequently we can do, and Dorcas, who was working with me, she has published this, and a duration of 20 to 90 minutes per session, 3 to 5 sessions a week, and for upper limb and lower limb, this is a protocol, 20 to 60 minutes a day for 5 days a week, and for lower limb, 15 to 60 minutes per day. Constraint-induced therapy, already Dr. Abhishek had mentioned, and there are 3 major components. One is it is repetitive and high-intensity therapy for upper limb, and we could restrain the upper limb. What we do here is these are the types of restraints that we use, and we involve these patients in multiple activities. So from the EXCITE trial, there is a minimum criteria that there need to be some 10 degrees active wrist extension, thumb abduction, and also we need to look at the spasticity. It should not be very severe spasticity. There should be some movement in the shoulder flexion and abduction, and also elbow flexion, and with minimal cognitive dysfunction. So these patients will benefit with CIMT, and these are some of the restraints that can be used. There is an effort to come up with some modified CMT, and the different protocols are available. People have found that throughout the waking day, if you make them to do, they may not be able to do it at all. So you can split it, 30-minute session or 3 sessions per week for 10 weeks. And so you can modify the CMT according to patient's acceptance, how patient is able to participate. Robotics, I won't go into it, and then Dr. Abhishek and Dr. Surya covered, but there are different categories and types, but I will just focus on some low-cost robotic system that we are developing through the Department of Bioengineering in CMC Vellore. This is called plug-and-play robotic, which can be taken to their homes. And so currently it is primarily for hand functions, upper limb functions. We are doing some validation in our center. So it comes in a box, and you can quickly assemble. We can train the relatives, and they can do the therapy at home. We can look at gadgets for each part of the hand, so grasp, etc., wrist movement, and they can play the games. Yeah. So this is called Pluto, and probably after the validation study, this is a very pilot study which was done at patient's home, and there is home-based and the clinic-based. There is definitely some improvement in the FMA. So these are the different gadgets that they have. This is a plug-and-train robot for hand rehabilitation. There is another one which they have developed, and we are doing a validation study. Again, an immersive VR base for upper limb rehab. And yeah, the patients, it's again active assisted, as Dr. Abhishek mentioned earlier. Then they have a tabletop non-robotic simulations, where they can get involved in activities. It's a tabletop model with the initial measurement unit. We can measure the hand movement and the trajectory. They are in the development phase now, and once they are done, then we will try to validate this in patients. So computer game-based therapy, Dorcas was with me. She had a DBT grant, Wellcome Trust grant, and where this is in a non-immersive computer video games, where the objects that are used for activities of daily living, like for example, a glass or something, and then top of that glass, you attach a mouse which has a sensor which can detect the movement, and they can play the games. And these are some of the objects, like you can see the glass here, and the day-to-day objects can be used. And this was a varsity pilot trial, but there were a lot of feasibility issues. Patients were not coming to the hospital for therapy, and in terms of feasibility, it was not possible. But whatever patient that we recruited, there is a positive trend in terms of improvement in hand function. Task-oriented training, that's again, it's the modality that people use, and the repetition and task-oriented. training are very important. In terms of mobility, the gait, there are different ways that we can use, the robotics and simple balance training, virtual reality-based music therapy, Dr. Abhishek mentioned, and functional electrical stimulation. These are some simple exercises and for balance, which can be done in the unit, both OPD as well as IPD, and also you can train the relatives, and they can do it at their homes. So dynamic balance, and Dr. Abhishek mentioned about the circuit training, and so there are different ways that the simple things can be done, including vestibular ball exercises. The remaining part of the talk, I'll focus on the service delivery model in chronic stroke. And we tested I would say, in the subacute and chronic phase of stroke, a family-led rehabilitation, the ATTEND trial, where the relatives were trained when they were in the hospital, and then they delivered the therapy at their homes. And there was an independent blinded assessor who documented outcome at 3 months and 6 months. We recruited about 1,250 patients, and the trial was neutral. However, during the process evaluation, what we found was that patients and relatives wanted this type of model, the rehab being delivered at home. And currently, we are working on a model of, I think I will discuss later. The second one is family training and increasing the skills of the patient. And this is a study from Thailand, where again a similar model was approached, and they were able to show that the skills of the caregivers improved, and they were able to deliver the therapy at home, and there was some improvement in the outcome measures. In terms of community health workers, we have some evidence from South Africa, where this particular study looked at what can be done at their home in the villages. The community health workers were trained and in basics of care, particularly the care on the bed, changing sides, and bladder and bowel function, etc., so that some sort of community integration occurs and some rehabilitation occurs in their homes. So digital and technological solution based on the ATTEND trial, the lessons that we learned, we have come up with this proposal. Basically, what we missed in ATTEND trial was the monitoring and the frequency of the therapy, which we are planning to circumvent through this particular app. And there is another app called Care for Stroke, web-based smartphone-enabled education intervention, which has been done by Dr. Suresh Kumar, and still we are waiting for the results of this particular trial. And in terms of models that are available, doctors said, I think this is already published, this particular paper in Annals of Indian Academy of Neurology. One is a typical MDT model, that in many tertiary care hospitals and comprehensive stroke care programs have. Then there's a care coordination model. There's a nodal point of person, it could be a nurse or a rehabilitation specialist, and they coordinate with the caregiver. And this has been successful in Parkinson's disease. One-stop clinic approach, the MDT team, one of the members evaluate, and then they try to integrate them into the community. Task shifting and caregiver model, I already mentioned. Step-down model of care, again, from a higher care, use community integration, either by task shifting or caregiver model, or has sent somebody to their homes. And digital model of care, which already I had mentioned, through various apps and telestroke rehab, and self-help model, that is self-management. There are some education materials, DVDs, videos are available, and the patients can see at homes, and they can do the therapy at their homes. There is a new concept called connected rehab gym, again in the digital technology platform. For each of the requirements, you have different applications which can be used in a common digital therapy platform. Finally, I'll touch upon alternative medicine and stroke rehab. This is one of our earlier studies, observation studies, looking at what proportion of our patients use alternative medicine. Close to 50% of our patients use alternative medicine, and largely it is Ayurvedic massage therapy. There are many other therapies that they use, but almost close to 50% of our patients, in addition to whatever we advise, they follow this. And in the Indian Stroke Clinical Trial Network, we designed the study, the RESTORE trial. Dr. Shailaja is a PI. Dr. Sunil Narayan is also one of the co-PIs, and where we try to compare the safety and efficacy of Ayurveda and conventional physiotherapy in the rehabilitation of post-stroke patients. This was a superiority trial. We wanted to look at the safety and efficacy of Ayurvedic treatment against the conventional physiotherapy. And if they were randomized to the intervention arm, they received a common protocol-driven treatment. That was given weekly, and they have to be admitted in an Ayurveda hospital. And in addition, they were given these medications, Ayurveda medication, for 14 days. Patients with ischemic stroke between 18 to 70 years of age, between 1 to 3 months, we randomized with MRS of 3 to 4. And primary efficacy was efficacy outcome was FMA upper extremity score at 3 months. And the study was done in 4 centers in our country. Dr. Sunil Narayan and then Dr. Shailaja, and from Amrita, Dr. Vivek. So we screened about 403 patients. Finally, we recruited 70 in each group. And this is a primary outcome. Our hypothesis was Ayurvedic treatment would be superior to physiotherapy, but what we found was Ayurvedic treatment was not superior to physiotherapy alone. And even from baseline to follow-up, and also in between the groups, the physiotherapy group did well, including several secondary outcome measures. This is the first study in the world that we are able to show that Ayurvedic treatment is not superior to conventional therapy. This particular protocol, no, we can't completely pass it off about the alternative medicine, but needs to be tested further. And safety, there were a lot of concerns about safety, but there was no difference in terms of SAEs. So in conclusion, the stroke rehabilitation in chronic phase is possible. There are several evidence-based interventions. Low-cost robotic technology is coming up, and home-based rehabilitation and telestroke rehabilitation is the best way to go. If they come to the hospital every day, if they are admitted in hospital for a long term, that is the best way to do. But with so many social constraints that we have, so we need to come up with some newer ways of taking care of these patients. And there is, I would say, there is a big room for innovation and implementation research opportunities in this area, particularly for India with so much of diversity that we have. And I sincerely thank my rehab team, and thank you very much.
Thank you, Dr. Pandian. So all of you would agree that we have had a very excellent and exhaustive overview of the rehabilitation of in stroke. Dr. Nirmal Surya, starting with a good overview of how the physiological changes in the acute stroke phase, not only in the brain, but also the cardiovascular system and other system is important, and how we can modify these things, and how these physiological factors have to be taken care of in the acute rehabilitation, and also about the timing. And then Dr. Abhishek has shown us a very exhaustive overview of almost every possible interventions, rehabilitative interventions. And Dr. Pandyan has taken us not only to the chronic phase rehabilitations, various techniques, but also how to reinvent ourselves and to critically look at the various processes and how to improve upon them in a holistic way, and also the trials like using indigenous medicine. I must tell you that I have had the opportunity to visit the Ambani Center where Dr. Abhishek he has set up this excellent facility. And recently I had the opportunity to visit Dr. Pandyan's own center with his excellent rehabilitation team. And, you know, Dr. Nirmal and Dr. Abhishek are working close together. And even Aravind at Zydus Hospital, very early stages around a decade back I had visited. I'm sure that lots of newer things have also come up there. So I will strongly encourage all of you who are stroke physicians and also interested in stroke rehabilitation to, if you get an opportunity to visit these places, we also have some very good facilities, especially in the non-invasive brain stimulation and robotic rehabilitation at JIPMA. So please do feel free to visit the places, and you will be certainly getting newer ideas, and we'll be able to share, and we can also learn a lot from all of you. So with this introduction, I think that we should, we have some, Aravind, you want to?
Yeah.
You have
sure.
comments?
No. Thank you, Dr. Sunil Narayan. Thank you for that overview we have given for all the three speakers. Excellent talk by all the three speakers on this World Stroke Day to encourage people to get involved in rehab, which is one of the part of stroke treatment and which is very important part. And one of the question in the question and answer session, I think, is for Dr. Nirmal. What is the incidence of patient fall in the very early rehabilitation and early out of bed activity?
Okay, so thank you very much. I think there are not many incidents of fall during the very early rehabilitation, but there are papers which has come for the incidence of fall during the hospital in the stroke rehabilitation. And one of the paper I remember, which is a very large study of 238 patients, where they reported 88 patients out of these 238 patients had a fall during their inpatient rehabilitation of the stroke. And there were some patients who have more than one fall. Now they identified that these fall was not very significant, but those patients who have a low FIM scale or who have a hemi-neglect or the severe deficiency, they are the one who has the tendency to fall. Also, most of the patients has fallen while they were being shifted into the wheelchair out of the bed. So what we need to do is we need to really look at those patients who have hemi-neglect, and if you are shifting them out of the bed into the wheelchair, you need to do it properly with a proper positioning. So you can identify who are the patients who are at the risk of fall, and you can definitely prevent that.
Yeah. So
Thank you.
Can I add, Dr. Arvind?
Yes. Yeah, sure, Dr. Jack.
Yeah. So the falls, Dr. Abhishek mentioned about the FLAME trial, and he also mentioned about the escitalopram. The failure of the subsequent trials, the fluoxetine trials, the SAE, the falls. So again, I don't know what was the direct mechanism of fall, maybe because these guys were sedated, they were elderly. And that was one of the reasons, both the trials did not show the positive effect of fluoxetine. But how the escitalopram, how does it differ in terms of falls and in terms of outcome?
So in the TELOS trial, the falls were not significant as compared to the other group. It is quite safe. And they've shown even the cardiovascular side effects, which were seen in their previous studies, were not there. So both falls as well as CV mortality was not much as compared to the placebo group. And plus, these patients have slightly better trend of the motor recovery. That's being approved by European Stroke Association now for motor recovery.
Thank you. Going to the next one.
Also, one more point is that those who are cognitively affected, they tend to have more fall as compared to those who are cognitively normal. So obviously we can find out who are the patients who are at risk, hemi-neglect, cognitive affected, and of course, as Jairaj has mentioned, those who are on drugs like escitalopram can be the one.
Very rightly said, and thank you for adding the point, Dr. Nirmal. Now, Dr. Abhishek has already mentioned about the neuronal plasticity, and you should not expect that recovery stops. That is the next question by Satya Murthy. When we expect the last recovery of a stroke patient? That is the endpoint. What is the endpoint where we stop thinking that patient will? I think this is what question the listener, the delegate want to ask. So all the three can. First, Dr. Abhishek can pitch in, right? He talked about the neuronal plasticity. Yeah.
So I think there are different sub-components for, like, for example, for motor recovery. The spontaneous motor recovery or getting newer movements will stop at 6 months after stroke. You can have better functional outcome, functional recovery up to 2 3 years post-stroke also. We have published, there were Neyman's time, people who were 2 years to 10 years post-stroke, who were trained for 6 weeks of inpatient rehab, 1/3 learned to walk. So mobility is still possible. Hand function will never come. People have power and hip flexors and knee extensors. When they pass through better train them, they learn to walk. So functional recovery is still possible. Second is cognitive recovery, speech language recovery. People with aphasia, Gandolfi et al. In Italy has seen one patient for every 6 months for 25 years. And they have published long back that their verbal output and was much better every year. I have right now with us in our hospital about 100 patients who are more than 5 to 10 years post-stroke. And they are followed with us every 6 months. And they are on medication plus basic home therapy. And many people with global aphasia are still changing. So aphasia, because the right brain is lying vacant, which can take over speech language function. Motor recovery for getting new movements, not possible beyond 6 months. Functional recovery, mobility, many years. Speech language recovery, many, many years. If they're doing therapy.
Yes.
So we have done a study about 5 years ago where we have taken the patients more than 3 years and 5 years of stroke. They were put on intensive therapy for both with hemiplegia and aphasia. And we did the DTI, gave them a extensive therapy for 3 months. And we could see the change in the fiber connectivity in this patient on MRI, and there's significant improvement in both speech and motor function. So I think depending on the individual patient, we can't just stop that 6 months or 1 year, the patient will not recover further. There are patients who still can recover maybe 5 years and 10 years, as Abhishek has mentioned. It all depends on how much therapy they have received in the past, how much their brain connectivity still can be achieved through the neuroplasticity, and can their neurons which are deactivated can be activated. So we still don't know much about this mystery. And I think we still need to, open this lock of mystery of the neuronal plasticity.
Yeah, I fully agree. It depends upon the motivation of the patient and how we take care of the patients. And the more we encourage them using an MDT approach, they'll be with us and they'll be motivated. And the family support is very, very crucial. If you don't have a family support, it is very, very difficult. Unlike, high-income countries where the government sends a vehicle to pick them up from the home and take them to the rehab center and then drop them. And in India, that is not possible.
Totally agree with that part. So last recovery part, as told by all the three speakers, different component have different time for the recovery, but you should not make a disheartening statement to the patient. And now coming the same question.
Arvind, just one comment that I was
Yes.
also amazed by during this last WC, and the professor from Japan, I don't exactly remember the name now, but he was showing, there was a workshop of Botox by him. I'm sure that Abhishek also has the same experience. He showed several patients of very long-standing stroke with severe spasticity, and how doing Botox injection at that stage for the spasticity significantly improved, not just we sometimes worry about loss of power, etc., but how the entire functionality of the hand improved, even in such very long-standing strokes with the spasticity. It was something which I learned for the first time, that even such a long-standing cases, there can be such a lot of improvement by the proper selection of the patient and in the way we do these things properly. So I think there is scope for improving the function even at very late stages. I think we have more further questions now.
Yes, thank you. Thank you for that comment, Dr. Sunil. And there are 3 more questions, I think, in 4 minutes left. And they are important questions, what I can see. The next is coming to the brain-computer interface, the prospect and availability of the brain-computer interface in India by Dr. Shwanshu.
So I have been on the panel of a certification of Government of India for the brain-computer interface. And I have been attending various meetings across the globe. The last conference was in September in China from the brain-computer interface. And I can tell you that there are a lot of actions been happening in our country. There are a lot of experiments are going on. There are a lot of activities are being done. The government is also promoting the various promoting and financing them. So you will see that next 2 or 3 years of time, the brain-computer, new gadgets of the brain-computer interface, both for the visual, auditory, hand functioning, and the other would be available to us. ICMR is also funding a couple of projects. Jairaj will also know. I'm on the Disability Expert Committee, and I know of sure that there are a couple of projects which are running through. It's a matter of time, and I think we really need to work together to come out with low-cost brain-computer interface, because the cost is one thing which is going to be a major factor in these new gadgets. But I'm very hopeful that next 2 or 3 years, India will see their own BCI devices in various.
We should take a global leadership with both Dr. Pandin and Nirmal and all now very much active in the world stroke field, stroke organizations. I think there is a very good opportunity for India to take lead.
Sunil, the biggest challenge is that we as a scientist know nothing about brain-computer interface.
Absolutely.
Engineer are working. They do not know anything about the brain problems and the rehabilitation process. And therefore, the time has come when we really need to work together, multidisciplinary team, researcher, scientists, the biomedical engineer, the engineer, IIT guys, come together along with the patient. I am again and again saying this because unless we all come together and work out on a formula and work on the cause, it is not going to work. And I also spoke about this in Rehab Week at Singapore. Guan was there, and we also had very major discussion between various robotic company and the researcher and the consultant. And we said we need to work together on a common platform along with the patient. I think this will happen because we are now knowing what we want to do. It's just a matter of time that we all come together and work together.
You must be knowing in 2013, we had this neurobionics conference at JIPMER. And again, now under the encouragement from all of you, we are planning to host this 2014 IFNR conference at JIPMER, and we are definitely going to allocate a very important part of this conference to the BCA and other tools where the engineers and doctors have to work together.
Yeah, I'll just make a quick comment. And we had a joint grant with IIT Kharagpur to develop this BCI for hand rehabilitation exoskeleton. The prototype is ready, but the problem I see is they are not so active. I keep on sending them messages. No, please, you send the prototype. We will test in patients, and they are pretty slow. I think, as Dr. Nirmal said, we need to really bring to people and push them, and finally they have to do it. No, we have the idea, but they have to execute that. Yeah.
Just a comment. About 10 years back, Dr. Ranjan T from Ahmedabad made all the devices very, very low cost. But there were no buyers. The company was closed.
Oh.
So now the awareness has come in last 10 years. People are able to afford those systems now, actually.
Absolutely. So I think there are many questions, but I will go to the last one. Does a patient who has achieved a maximum functional ability and reached a plateau of the phase of post-stroke still need to continue some amount of rehabilitation for maintenance purpose? If yes, then how long, Dr. Abhishek? If you can give the...
So some type of exercise is required to, it's called as maintenance rehab. So a lot of work is now happening on improving endurance component in stroke survivors. Someone who has survived a stroke is independent, but can gain weight, can have new problems. So they should be able to at least exercise 5 times a week, focusing on 4 components: strength, strengthening, stretching, endurance, and balance training. Even geriatric population recommendations are same. 3 to 5 days a week, 4 component training is must to maintain level of functionality.
Fantastic. So last question I will put up as it is 6:30, which is important even for the tilt table, which Dr. Swanshu has asked. Any concern regarding autonomic dysfunction while early mobilization, Dr. Nirmal?
I think tilt table is a fantastic way. What you need to do, I have put the patient as early as within 72 hours. We need not take them complete 180 degree. We can go slowly. We can take the patient first 35, 40 degree, then patient tolerate, go to 60, 80. So tilt table gives you enough cushion and time to make the patient stable. And I think those patients who cannot strain with grade 1 power in the leg, tilt table is the best thing to have, and they are always help you to maintain and get the patient better. So I think tilt table in ICU is regularly, we have been doing it. And this is a fantastic result. Everybody, every intensive care unit should have it. It will help you to mobilize the patient early, overcoming the autonomic dysfunction.
Arvind, we can just allow this very last question on ataxia also.
Ataxia one. Okay. Along with ataxia, yes. How the prognosis?
Yes.
So
ataxia is a challenging problem, but one good thing is all the stroke ataxia, given the proper therapy and treatment, gait training, and with the robotic available, ataxic patient can also be made to walk as early as 1 week. So most of the patient improves. It is only a matter of proper programming for this patient. I don't see ataxia, even Wallenberg syndrome or cerebellar ataxia, we have problem. We have even taken the patient, our paper on treadmill training with cerebellar ataxia. Many of these patients has done very well. It does take time as compared to the other weakness, but they do very well.
So I would like to thank all the speakers and my co-chair. I will, before handing over to my co-chair, Dr. Sunil, and to Gohan, Dr. Nirmal, Dr. Jairaj, and Dr. Abhishek for a wonderful talk and in the explanation for all the questions and all the participants who participated in this. I hand over to my co-chair, Dr. Sunil, and moderator, Dr. Gohan. Thank you very much.
So happy that we have had this meeting today with rehab as a very important, as a core issue. A huge chunk of patients after the acute care go back home, and there is a this was almost a blind spot. We don't know what's happening to them until they develop another stroke or somehow or others, they come to know and they reach the hospitals. So, there is a lot of emphasis on the quality of life, and we want all stroke patients to come back and join the mainstream, and if possible, try to regain their earning capacities and lead a enjoyable family life, enjoyable, happy life. So it's very, very crucial to give them maximum functionality as possible. And hence the emphasis on rehab is going to increase, because lots and lots of stroke patients are going to survive. And we have had this today's symposium emphasizing and giving a very good overview of all the phase of rehabilitation. And it was a great honor to be able to chair this session, and thank all the speakers and the participants who have, we still have some of the questions not answered. And we have had a very good participation on this cricket match day between India and England. We still have around 70 plus participants, and I'm sorry we would allot out some of the listeners. Yeah, so, and there is I also want to thank one word of appreciation of Guhan. Like we all know, it's great to have a very young, dynamic person steering and leading this. So it's a great pleasure, Guhan, to have you with us. And I would now hand over the proceedings to.
Thank you very much, Dr. Sunil sir, for the kind words. For that specifically, I would like to acknowledge Dr. Nirmal Surya sir, because the first time he gave me that opportunity, I asked him, sir, would I be able to do it? Then he told, you should start, initiate. And that has given a lot of confidence to me. Thank you very much for that, sir.
You may also tell about the our conference coming up, IFNR, in April, second week, yes. 14th to 16th April.
Yes, sir. With the permission of the president of IFNR and the chair of the Neuro Rehab subsection of the IAN, I would like to invite you all for the Indian Federation of Neuro Rehabilitation Conference that's going to be held in the year 2024. With so many exciting events that has been planned for that day, for the series of days. And further, you can follow up on the IFNR website regarding the details of the conference, where it will be updated regularly. And it was a wonderful session that we had so far. And every time I listen to these speakers, it's like what we call an Akshaya Patram, that new information keeps coming. And there's never ending to that. And thank you very much for the wonderful session. On behalf of the Neuro Rehab subsection of the IAN and IFNR, I sincerely thank the esteemed chair, Dr. Sunil sir and Dr. Arvind sir, and the elite panel of speakers, Dr. Nirmal Surya sir, Dr. Abhishek sir, and Dr. Jairaj Pandian sir, for allotting their time on this busy World Stroke Day. I thank the IAN President, Dr. Debashish sir, and Dr. IAN Secretary, Dr. U. Meenakshi Sundaram sir. I thank the audience for attending the illustrious session today while the India-England World Cup match was happening. Probably not, India was not doing very great today, and we'll wait and see what happens next. And I thank the IAN digital team, Bhavesh sir, Manasi ma'am, Ashmita ma'am, for the wonderful support they have rendered in communicating with regards to the conference. Thank you very much.
Thank you.
Thank you. Thank you.
Thank you very much.
Thanks, everybody.
Thank
Thank
you.
Thank you, everyone. Thank you.
Thank you very much, sir.
Bye, Guhan. Take care. Bye-bye.
Bye, sir. Thank you so much, sir.